Color plates. Plate 1, infant with fetal alcohol syndrome. Note short palpable fissures, myotosis, nostrils, smooth filtrum, and narrow vermilion of the upper lid. See figure 2.1, p. 26, from Gilbert Barnes E. Potter's Pathology of the Fetus, Infant and Child, 2nd ed. Philadelphia, Elsevier, 2007, Fig. 4.1.12. Activate windows. Plate 2, xanthelasma. Multiple soft, yellow plaques involving the lower eyelid. Xanthelasma is usually a normal finding with no significance, but is classically seen on the usmle because of its association with hypercholesterolemia. Screen affected patients with a fasting lipid profile. See figure 5.1, p. 52, from Yanoff M. Duker J.S. Ophthalmology, 3rd ed. Philadelphia, Mosby, 2008, Fig. 12.9.18. Plate 3, allergic contact dermatitis of the leg caused by an elastic wrap. Notice the well-marginated distribution that differentiates it from cellulitis. See figure 6.1, p. 55. From Alba P.S. Wilderness Medicine, 6th ed. Philadelphia, Mosby, 2011. Plate 4, tinea corporis. Red ring-shaped lesions with scaling and some central clearing. See figure 6.2, p. 56. From Kliegman Oran. Nelson Textbook of Pediatrics, 19th ed. Philadelphia, Saunders, 2011. Plate 5, pityriasis rosea. Small oval plaques as well as multiple small papules are present. See figure 6.3, p. 59. From Habif TP. Clinical Dermatology, 5th ed. St. Louis, Wesley, 2009. Plate 6, lichen planus. Flat top, purple polygonal papules of lichen planus. See figure 6.4, p. 60. From Kliegman Oran. Nelson Textbook of Pediatrics, 19th ed. Philadelphia, Saunders, 2011. Plate 7, erythema multiforme. Bullseye. Annular lesions with central vesicles and bully. See figure 6.5, p. 60. From Goldman L. Goldman Cecil Medicine, 24th ed. Philadelphia, Saunders, 2011. Plate 8, erythema nodosum on the legs of a young woman. See figure 6.6, p. 61. From Hodgberg MC. Rheumatology, 5th ed. Philadelphia, Mosby, 2010. Plate 9, bullous pemphigoid. Test of the epidermal bully on an erythematous base. See figure 6.7, p. 61. From Goldman L. Goldman Cecil Medicine, 24th ed. Philadelphia, Saunders, 2011. Plate 10, dermatitis herpetiformis is characterized by pruritus, urticarial papules, and small vesicles. See figure 6.8, p. 62. From Feldman M. Schlesinger and Fortran's gastrointestinal and liver disease, 9th ed. Philadelphia, Saunders, 2010. Courtesy Dr. Timothy Berger. San Francisco, Calif. Plate 11, melanoma superficial spreading type. See figure 6.9, p. 63. From Goldman L. Goldman Cecil Medicine, 24th ed. Philadelphia, Saunders, 2011. Plate 12, keratoconthoma on the right upper lid. Lesions are solitary, smooth, dome-shaped red papules or nodules with a central keratin plug. See figure 6.10, p. 64. From Albert D.M. Albert and Jacobik's Principles and Practice of Ophthalmology, 3rd ed. Philadelphia, Saunders, 2008. Plate 13, keloid of the earlobe after piercing. See figure 6.11, p. 64. From Kliegman R.M., Stanton B.F., St. Jean J.W. Roman 3, et al. Nelson Textbook of Pediatrics, 19th ed. Philadelphia, Saunders, 2011. Plate 14, an ulcerated basal cell carcinoma with rolled borders on the posterior ear. See figure 6.12, p. 65. From Abloff D.A., Armitage J.O., Niederhuber J.E., et al. Abloff's Clinical Oncology, 4th ed. Philadelphia, Churchill Livingstone, 2008. Activate windows. Plate 15, squamous cell carcinoma on the lower lip. See figure 613, p. 65. From Rachel Reed, Rachel D.P. Textbook of Family Medicine, 8th ed. Philadelphia. Saunders, 2011. Richard P. Usertan. Plate 16, multiple actinic keratosis visible as thin, red, scaly lesions. See figure 614, p. 66. From Goldberg D.J. Procedures in Cosmetic Dermatology. Lasers and Lights, Vol 1. 2nd ed. Saunders, 2008. Plate 17, nailed melanoma. See figure 615, p. 67. From Goldman L. Schaefer Al. Goldman Cecil Medicine, 24th ed. Philadelphia. Saunders, 2011. Plate 18, Paget disease of the nipple. Note the erythematous plaques around the nipple. See figure 616, p. 67. From Les GM, Lobo Rod, Jershenson DM, Cattsville. Comprehensive Gynecology, 6th ed. Philadelphia. Mosby, 2011. Originally from Callan JP. Dermatologic signs of systemic disease. In Bologna JL, Jorizo JL, Rapini RPS. Dermatology. Edinburgh, Mosby, 2003. p. 714. Activate Windows Code 05. Plate 19, multiple pattern cafe or late spots in a child with McCune-Albright syndrome. See figure 10-2, p. 86. From Eichenfield LF. Frieden IJ, Esterly MB. Neonatal Dermatology, 2nd ed. Philadelphia. Saunders, 2008. Fig. 22-3. Plate 20, colonoscopic photograph of a pale colon cancer easily seen against the dark background of pseudomelanosis colon. See figure 12-3, p. 95. From Feldman M. Friedman LS. Brand LJ, AIDS. Schlesinger and Fortran's gastrointestinal and liver disease, 9th ed. Philadelphia. Saunders, 2010. Fig. 124A. Courtesy Julia Nord, MD, Tampa, Florida. Plate 21, mucosal pathology and celiac disease. A. Duodenal biopsy specimen of a patient with untreated celiac disease. The histologic features of severe villus atrophy. Arrow 1. Crypt hyperplasia. Arrow 2. Intracyte disarray. Arrow 3. An intense inflammation of the lamina propria and epithelial cell layer. Arrow 4 are evident. B. Repeat duodenal biopsy after 6 months on a strict gluten-free diet. There is marked improvement with well-formed villi. Arrow 5 and a return of the mucosal architecture toward normal. See figure 12-5, p. 97. From Feldman M. Friedman LS, Brand LJ. Schlesinger and Fortress. Gastrointestinal and liver disease, 9th ed. Philadelphia. Saunders. Plate 22, chronic viral hepatitis. Portal bridging fibrosis is seen in long-standing chronic hepatitis C. See figure 12-8, p. 102. From Izar D. Goldman Jr. Surgical pathology of the GI tract, liver, biliary tract, and pancreas, 2nd ed. Saunders, 2009. Fig. 38-10. Trachea, bronchi, proximal esophagus, tracheoesophageal fistula, distal esophagus. Plate 23, tracheoesophageal fistula. Diagram of the most common type of esophageal atresia and tracheoesophageal fistula. See figure 12-11, p. 108. From Gilbert, Barnes E. Potter's pathology of the fetus, infant, and child, 2nd ed. Philadelphia. Mosby, 2007. Fig. 25.6. Plate 24, abdominal wall defects. A. Omphalosal with intact sac. B. Gastroschisis with eviscerated multiple bowel loops to the right of the umbilical cord. See figure 12-13, p. 110. From Sabiston, D.C., Townsend CM. Sabiston Textbook of Surgery, the Biological Basis of Modern Surgical Practice, 19th ed. Philadelphia. Saunders, 2012. Fig. 6720. Plate 25, Henneck Schernlein purpura in a 7-year-old child. No typical red-purple rash on the lower extremities. See figure 12-14, p. 111. From Morgs J.A., Hoppinger RS, Walls RN. Rosen's Emergency Medicine, Concepts in Clinical Practice. 7th ed. Mosby, 2009, Fig. 17010. Courtesy Marion Gouch Hill, MD. B. Plate 26, Edwards Syndrome. A. Note the small head, prominent occiput, and low set, malformed ears. B. Clenched hand with overlapping fingers. See Figure 410-2. P. 127. Kasky J.J. Clinical Diagnosis in Ophthalmology. 1st ed. Philadelphia, Mosby, 2006, Fig. 15.10. Courtesy B.J. Zitelli and H.W. Davis. Plate 27, Turner Syndrome. This 13-year-old female demonstrates the classic webbed neck and triangular faces of Turner Syndrome. She has sexual infantilism and short stature. See Figure 410-3, P. 128, Mashing T. A. Pediatric. Endocrinology. The Requisites in Pediatrics. 1st ed. St. Louis, Mosby, 2005. Plate 8-2. Plate 28, Morphin Syndrome. Arachidactyly in a patient with Morphin Syndrome. See Figure 410-4, P. 129. Stapper RL, Lieberman MF, Drake MV. Becker Schaffer's Diagnosis and Therapy of the Glaucomas. 8th ed. Philadelphia, Mosby, 2009, Fig. 19.41. Plate 29, Pigment gallstones within it. Otherwise unremarkable gallbladder are a marker for hemolytic anemia. See Figure 17-1, P. 145. From Kumar V. Abazake, Forresto N. Astor J.C. Robbins and Cochran Pathology Basis of Disease, Professional. Edition, 8th ed. Philadelphia, Saunders, 2009, Fig. 1853. Plate 30 sickle cells show a sickle or crescent shape resulting from the polymerization of hemoglobin S. This smear also shows target cells and boat-shaped cells with a lesser degree of polymerization of hemoglobin S than in a classic sickle cell. See Figure 17-2, P. 145. From Goldman L. Schaefer Al. Goldman Cecil Medicine, 24th ed. Philadelphia, Saunders, 2011. Plate 31, megaloblastic changes of macrocytosis and a hypersegmented neutrophil. See Figure 17-3, P. 146. From Rachel Reed, Rachel D.P. Textbook of Family Medicine, 8th ed. Philadelphia, Saunders, 2011, Fig. 39-4. The American Society of Hematology Image Bank, image number 2611. Copyright 1996, American Society of Hematology, used with permission. Plate 32, iron deficiency anemia. Pale red. Blood cells with enlarged central pallor. See Figure 17-4, P. 146. From McPherson R. Pincus M. Henry's Clinical Diagnosis and Management by Laboratory Methods, 21st ed. Philadelphia, Saunders, 2006, Fig. 31-2. Plate 33, basophilic stippling. Irregular basophilic granules in red blood cells, often associated with lead poisoning and thalassemia. See Figure 17-5, P. 147. From McPherson R. Pincus M. Henry's Clinical Diagnosis and Management by Laboratory Methods, 21st ed. Philadelphia. Activate windows. Plate 34, biax cells with Heinz bodies. See Figure 17-6, P. 147. Courtesy Dr. Robert W. McKinnon, Department of Pathology. University of Texas Southwestern Medical School, Dallas, Texas. Plate 35, Howard-Jelly bodies and peripheral blood erythrocytes. These nuclear remnants indicate lack of splenic filter dysfunction. See Figure 17-7, P. 148. From Orkin S.H. et al. Nathan and Oscar's Hematology of Infancy and Childhood, 7th ed. Philadelphia, Saunders, 2009, Fig. 14-4. Plate 36, teardrop red blood cells, usually seen in myelofibrosis. See Figure 17-8, P. 148. From Goldman L. Ocello D. Cecil Medicine, 23rd ed. Philadelphia, Saunders, 2008, Fig. 16113. Plate 37 schistocytes and helmet cells. Red blood cell fragments seen with microangiopathic hemolytic anemia and disseminated intravascular coagulation. See Figure 17.9, p. 148. From McPherson R., Pincus M., Henry's Clinical Diagnosis and Management by Laboratory Methods, 21st and Philadelphia, Saunders, 2006, Fig. 2919. Plate 38 Hereditary elliptocytosis. Blood film reveals characteristic elliptical red blood cells. See Figure 1710, p. 149. From McPherson R., Pincus Mr. Henry's Clinical Diagnosis and Management by Laboratory Methods, 22nd and Saunders, 2011, Fig. 3016. Plate 39 acanthocytes. Irregularly spiculated red blood cells, frequently seen in beta-lipoproteinemia or liver disease. See Figure 1711, p. 149. From McPherson R., Pincus M., Henry's Clinical Diagnosis and Management by Laboratory Methods, 21st and Philadelphia, Saunders, 2006, Fig. 2920. Plate 40 target cells are frequently seen in hemoglobin C disease and liver disease. See Figure 1712, p. 149. From McPherson R., Pincus M., Henry's Clinical Diagnosis and Management by Laboratory Methods, 21st and Philadelphia, Saunders, 2006, Fig. 2918. Plate 41 echinocytes, or burst cells arrows, are the hallmark of uremia. See Figure 1713, p. 150. Hoffman R. et al. Hematology, Basic Principles and Practice, 5th and Philadelphia, Churchill Livingstone, 2008, Fig. 156-1. Plate 42 microangiopathic hemolytic anemia demonstrating red blood cell fragments, anisocytosis, polychromation, and decreased platelets. See Figure 1714, p. 150. From T. or KM, Editors, The Harriet Lane Handbook, 19th and Philadelphia, Wasby, 2011, Plate 7. Plate 43 Rulo formation of stacked red blood cells seen in multiple myeloma. See Figure 1715, p. 150. From Goldman L. Arcelo D. Cecil, Medicine, 23rd and Philadelphia, Saunders, 2008, Fig. 16119. Plate 44 Malaria. Peripheral blood film examples of various stages of Plasmodium falciparum. A. Small ring forms. B. A crescentic gametocyte with centrally placed chromatin. See Figure 1716, p. 151. From Hoffman R. et al. Hematology, Basic Principles and Practice, 5th and Philadelphia, Churchill Livingstone, 2008, Fig. 159-5. Plate 45 ring sideroblasts seen in sideroblastic anemia. See Figure 1717, p. 151. From Goldman L. Arcelo D. Cecil Medicine, 23rd ed. Plate 46 patch testing. A battery of common and suspected allergens is applied to the back with a patch for 48 hours and then removed. The skin is then examined at 96 hours. Irritant reactions disappear. Allergic ones do not. This patient has many positive reactions of varying intensity. C. Figure 19.1, p. 166. From HABIF-TP. Clinical Dermatology, 5th ed. St. Louis, Mosby, 2009, Fig. 430. Plate 47 penile chancre in a patient with primary syphilis. See Figure 23, p. 179. From YWS et al. Editors, Campbell-Walsh Urology, 10th ed. Philadelphia, Saunders, 2011, Fig. 13-7. Plate 48 Palmer, lesions of secondary syphilis. C. Figure 24, p. 179. From Mando G.L. Bennett, G. Dahlin R. Mandel, Douglas, and Bennett's Principles and Practice of Infectious Diseases. 7th ed. Philadelphia, Churchill and Livingstone, 2009, Fig. 238.5. Activate Windows. Play 49 slap cheek appearance of erythema infectiosum. See Figure 25, p. 180. From Baron J.M., Rothrock S.G., Brennan J.A., Brown, L., Pediatric Emergency Medicine, 1st ed. Philadelphia, Saunders, 2007, Fig. 123.5. Play 50 herpes zoster. Group vest copustules on an erythematous base. See Figure 26, p. 181. From Morgs J.A., Rosen's Emergency Medicine, 7th ed. Philadelphia, Mosley, 2009, Fig. 118.28. Courtesy David Efron, M.D. Play 51 impetigo. Multiple crusted and oozing lesions. See Figure 27, p. 183. From Cleveland O.R.M., Stanton B.F. St. Jean J.W. Roman 3. Score N.F. Nelson Textbook of Pediatrics, 19th ed. Philadelphia, Saunders, 2011, Fig. 657.1. Play 52 sharply defined erythema and edema, characteristic of erysipelas. See Figure 2010, p. 188. From Zayudis L.B., Shang V.W. Comprehensive Pediatric Hospital Medicine, 1st ed. Philadelphia, Mosby, 2007, Fig. 156. Play 53 scalded appearance from widespread desquamation seen in staphylococcal scalded skin syndrome. See Figure 2011, p. 189. From Baron J.M., Rothrock S.G., Brennan J.A., Brown L., Pediatric Emergency Medicine, 1st ed. Philadelphia, Saunders, 2007, Fig. 126.4. Play 54 Hennig Sherline purpura. Non-blanchable macules and papules on the buttocks and lower extremities. See Figure 22.2, p. 197. From Tal M.W., Brenner and Rector's the Kidney, 9th ed. Philadelphia, Saunders, 2011, Fig. 59.20. Play 55-hour rods vary from prominent, as in this cell, to thin and delicate. See Figure 26.1, p. 241. From McPherson R.A., Pincus Mr. Henry's. Clinical Diagnosis and Management by Laboratory Methods, 22nd ed. Philadelphia, Saunders, 2011, Fig. 33.25. Play 56 chronic myelogenous leukemia showing myeloid blast phase. See Figure 26.2, p. 241. From Hoffman R., Benz EJJR, Chattel S.J., et al. Hematology, Basic Principles and Practice, 5th ed. Philadelphia. Play 57 a young boy from South America with typical endemic Burkitt lymphoma presenting in the mandible. See Figure 26.3, p. 242. From Jaffe S., Harris N.L., Vardaman J.W., et al. Hematopathology, 1st ed. St. Louis, Saunders, 2010, Fig. 24.1. Courtesy Prof. Georges Delso, Toulouse, France. Play 58 café-au-lait patches as well as multiple axillary freckles in a 14-year-old boy. See Figure 26.5, p. 244. From Hoyt C.S., Taylor D. Pediatric Ophthalmology and Strabismus, 4th ed. Edinburgh, Saunders, 2012, Figure 65.4. Play 59 a patient with superior vena cava syndrome and the characteristic venous dilation and facial edema. See Figure 26.7, p. 247. From Abloff M.D., Armitage J.O., Niederhuber J.E., et al. Abloff's Clinical Oncology, 4th ed. Philadelphia, Churchill. Play 60 Kaposi sarcoma. See Figure 26.14, p. 259. From Hoffman R., Benz EJJR, Chattel S.J., et al. Hematology, Basic Principles and Practice, 5th ed. Philadelphia, Churchill Livingstone, 2008, Fig. 120-135. Plate 61, primary nodular malignant melanoma found on back of patient. See figure 2615, p. 259. From Yanov M. Sassani J.W. Ocular pathology, 6th Ed. Philadelphia, Mosby, 2008, Fig. 17, 8A. Plate 62, a thick, sharply marginated focal leukoplakia of the ventral/lateral tongue with a uniform erythematous periphery. See figure 2616, p. 260. From Flint P.W., Hoy B.H., Naparko J.K., et al. Cummings Otolaryngology, Head and Neck Surgery, 5th Ed. Philadelphia, Mosby, 2010, Fig. 91.5c. Plate 63, a 12-year-old boy with orbital cellulitis. Note the poor elevation of the affected eye. See figure 27.1, p. 265. From Hoyt C.S., Taylor D. Pediatric Ophthalmology and Strabsmith, 4th Ed. Edinburgh, Saunders, 2012, Fig. 13.10 AI. Plate 64, varicella dendritic keratitis. Numerous dendrites are seen in this slit lamp photograph with fluorescein staining of the dendritic lesions from active viral growth in the corneal epithelium. See figure 27.2, p. 265. From Kratchmer J.H., Manny's M.J., Cornea, 3rd Ed., Philadelphia, Mosby, 2010, Fig. 80.2. Plate 65, leukocoria white pupillary reflex is the most common presenting feature of retinoblastoma and may be first noticed in family photographs. See figure 29.1, p. 279. From Kasky J.J., Clinical Diagnosis in Ophthalmology, 1st Ed. St. Louis, Mosby, 2006, Fig. 9.94. Courtesy U. Rainier. Plate 66, infantile hemangioma. These lesions grow rapidly during the first few months of life once they appear 20% at birth. But they are asymptomatic unless they bleed, become infected, or obstruct a vital structure. Complete resolution is typical before the age of 7 years, and no treatment is usually required. See figure 29.2, p. 282. From Duke Vivier, 8. Atlas of Clinical Dermatology, 3rd Ed., New York, Churchill, Livingstone, 2002, p. 117. With permission. Plate 67, osteoarthritic hands with Heberden, distal interphalangeal, and Bouchard proximal interphalangeal nose on both index fingers and thumbs. See figure 35.2, p. 316. From Canel S.D., BDJH, Campbell's Operative, Orthopedics, 11th Ed. Philadelphia, Mosby, 2007, Fig. 74. Plate 68, psoriasis, typical oval plaque with well-defined borders and silvery scale. See figure 35.3, p. 318. From Habai TP, Clinical Dermatology, 5th Ed. St. Louis, Mosby, 2009, Fig. 8.1. Plate 69, erythema migrans rash of Lyme disease. Bullseye lesion on lateral thigh. See figure 35.5, p. 319. From Firestein G.S., Bud R.C., Gabriel S.C., et al. Kelly's Textbook of Rheumatology, 9th Ed., Philadelphia, Saunders, 2012, Fig. 110.1. Courtesy, Juan Salazar, M.D., University of Connecticut Health Center. Plate 70, dermatomyositis. Heliatro, violaceous discoloration around the eyes and periorbital edema. See figure 35.6, p. 321. From Habib TP, Clinical Dermatology, 5th Ed. Philadelphia, Mosby, 2009, Fig. 1719. Plate 71, sharply demarcated, symmetric, depigmented areas of vitiligo. See figure 41, p. 337. From Cleveland RM, Stanton BF, St. Jean Moment 3JW, et al. Nelson Textbook of Pediatrics, 19th Ed. Philadelphia, Saunders, 2011, Fig. 645 4. 100 Top Secrets. These secrets are 100 of the top board alerts. They summarize the concepts, principles, and most salient details that you should review before you take the Step 2 examination. Understanding of these top secrets will serve you well in your final review. 1. Smoking is the #1 cause of preventable morbidity and mortality, e.g., atherosclerosis, cancer, chronic obstructive pulmonary disease in the United States. 2. Alcohol is the #2 cause of preventable morbidity and mortality in the United States. More than half of accidental and intentional, e.g., murder, suicide deaths involve alcohol. Alcohol is the #1 cause of preventable mental retardation, fetal alcohol syndrome. It also causes cancer and cirrhosis and is potentially fatal in withdrawal. 3. In alcoholic hepatitis, the classic ratio of aspartate Willdose, aminotransferase AST to alanine aminotransferase VAT, AL, is greater than or equal to 2:1, although both may be elevated. 4. Vitamins. Give folate to reproductive age women before pregnancy occurs to prevent neural tube defects. Watch for pernicious anemia and treat with vitamin B12 to prevent permanent neurologic deficits. Isoniazid causes pyridoxine vitamin B12 deficiency. Watch for Wernicke encephalopathy in alcoholic patients and treat with thiamine to prevent Korsakoff dementia. 5. Minerals. Iron deficiency anemia is the most common cause of anemia. Think of menstrual loss in reproductive age women and of cancer in men and menopausal women if no other cause is obvious. 6. Vitamin A is a known teratogen. Counsel and treat reproductive age women appropriately, e.g., take care in treating acne with a vitamin A analog isotretinoin. 7. Complications of atherosclerosis, e.g., myocardial infarction, heart failure, stroke, gangrene are involved in roughly 1/2 of deaths in the United States. The primary risk factors for atherosclerosis are age/sex, family history, cigarette smoking, hypertension, diabetes mellitus, high low-density lipoprotein LDL cholesterol, and low high-density lipoprotein HDL cholesterol. 8. Diabetes leads to atherosclerosis and its complications. Retinopathy, a leading cause of blindness, nephropathy, a leading cause of end-stage renal failure, peripheral vascular disease, a leading cause of limb amputation, peripheral neuropathy, sensory and autonomic, and an increased incidence of infections. 9. Although hypertension is most often mild or moderate and clinically silent, severe hypertension can lead to acute problems known as a hypertensive emergency: headaches, dizziness, blurry vision, papilledema, cerebral edema, altered mental status, seizures, intracerebral hemorrhage, classically in the basal ganglia, renal failure/azotemia, angina, myocardial infarction, and/or heart failure. 10. In milder cases, lifestyle modifications, e.g., diet, exercise, weight loss, cessation of alcohol/tobacco use may be able to treat the following disorders without the use of medications: hypertension, hyperlipidemia, diabetes, gastroesophageal reflux disease, GERD, insomnia, obesity, and sleep apnea. 11. Arterial blood gas analysis. In general, pH tells you the primary event acidosis versus alkalosis, whereas carbon dioxide and bicarbonate values give you the cause same direction as pH and suggest any compensation present opposite of pH. 12. Exogenous causes of hyponatremia. Keep in mind oxytocin, surgery, narcotics, inappropriate things to activate V, intravenous room and 4 fluid administration, diuretics, and antiepileptic medications. 13. Electrocardiogram ECG findings and electrolyte disturbances. Tau, 10-I waves in hyperkalemia, loss of I wave/T wave flattening and U waves in hypokalemia, QT prolongation in hypocalcemia, QT shortening in hypocalcemia. 14. Shock. First give the patient oxygen, start enrollment 4 line, and set up monitoring pulse oximetry. 8. Frequent vital signs. Then give a fluid bolus 1L normal saline or lactated Ringer solution if no signs of congestive heart failure, e.g., basilar rails are present while you investigate the cause. 15. Virtue triad of deep venous thrombosis DVT, endothelial damage e.g. surgery, trauma, venous stasis e.g. immobilization, surgery, severe heart failure, and hypercoagulable state e.g. malignancy, birth control pills, pregnancy, lupus anticoagulant, inherited deficiencies. 16. Therapy for congestive heart failure, diuretics e.g. furosemide, angiotensin-converting enzyme AC inhibitors, and beta blockers for stable patients are the mainstays of pharmacologic treatment. Be sure to screen for and address underlying atherosclerosis risk factors e.g. smoking, hyperlipidemia. 17. Cor pulmonale, right-sided heart enlargement, hypertrophy, or failure caused by primary lung disease, usually chronic obstructive pulmonary disease. The most common cause of right-sided heart failure, however, is left-sided heart failure, not cor pulmonale. 18. In patients with atrial fibrillation, assess for an underlying cause with thyroid-stimulating hormone TSH, electrolytes, and echocardiogram. The main management issues are ventricular rate if needed, slow the rate with medications, and atrial clot formation/embolic disease. Consider anticoagulation with warfarin. 19. Ventricular fibrillation and pulseless ventricular tachycardia are treated with immediate defibrillation followed by epinephrine, vasopressin, amiodarone, and lidocaine. If ventricular tachycardia with the pulse is present, treat with amiodarone and synchronized cardioversion. 20. Obstructive versus restrictive lung disease. The FEV1/FEV ratio is the most important parameter on pulmonary function testing to distinguish the two. FEV may be the same. In obstructive lung disease, the FEV1/FEV ratio is less than normal. In restrictive disease, the FEV1/FEV ratio is often normal. 21. The most common type of esophageal cancer is adenocarcinoma, occurring as a result of long-standing reflux disease and the development of Barrett esophagus. Smoking and alcohol abuse contribute to the development of squamous cell carcinoma, the second most common histology as type of esophageal cancer. Go to settings to activate. 22. A biopsy must be performed on all gastric ulcers, or they must be followed to resolution to exclude malignancy. 23. Testing a nasogastric tube aspirate for blood is the best initial test to distinguish upper from lower gastrointestinal GI bleeding, although bright red blood via mouth or anus is a fairly reliable sign of a nearby bleeding source. 24. Irritable bowel syndrome is one of the most common causes of GI complaints. Physical examination and diagnostic studies are by definition negative. This is a diagnosis of exclusion. The classic case is a young woman with a history of chronic alternating constipation and diarrhea. 25. Crohn's disease versus ulcerative colitis. Place of origin, thickness of pathology, progression, location, bowel habit, changes, classic, lesions, colon cancer, risk, surgery, distal ileum, proximal colon, transmural, irregular skip lesions, from mouth to anus, obstruction, abdominal pain, fistulas/abscesses, cobblestoning, string sign on barium X-ray, slightly increased, no may make worse. Ulcerative colitis, rectum, mucosa/submucosa, only, proximal, continuous, from rectum, no skip areas, involves only colon, rarely extends to ileum, bloody diarrhea, pseudopolyps, lead pipe colon on barium X-ray, toxic megacolon, markedly increased, yes proctocolectomy with ileonal anastomosis. 26. All forms of viral hepatitis can present similarly in the acute stage. Serology testing and history are needed to distinguish them. Hepatitis B, C, and DAO are transmitted parenterally and can lead to chronic VA infection, cirrhosis, and hepatocellular carcinoma. 27. Hereditary hemochromatosis is currently the most common known genetic disease in white people. The initial symptoms, fatigue, impotence, are nonspecific, but patients often have hepatomegaly. Screen with transferrin saturation test serum iron/total iron binding capacity and ferritin level. Treat with phlebotomy after confirming the diagnosis with genetic testing and liver biopsy. Hypoalbuminemia. 28. Sequelae of liver failure, coagulopathy that cannot be fixed with vitamin K. Jaundice/hypobilirubinemia. Sites. Portal hypertension, hyperammonemia/encephalopathy, hypoglycemia, and disseminated intravascular coagulation. 29. Pancreatitis is usually caused by alcohol or gallstones. Patients seek treatment because of abdominal pain, nausea/vomiting, and elevated amylase and lipase. Treat supportively and provide pain control. Complications include pseudocyst formation, infection/abscess, and adult respiratory distress syndrome. 30. Jaundice/hypobilirubinemia in neonates is usually physiologic only. Monitoring and follow-up laboratory tests are needed, but jaundice present at birth is always pathologic. 31. Primary versus secondary endocrine disturbances. In primary disorders, e.g., Graves, Hashimoto, or Addison disease, the gland malfunctions but the pituitary or another gland in the central nervous system respond appropriately, e.g., TSH, thyrotropin-releasing hormone TRH or adrenocorticotropic hormone act elevate or depress as expected in the setting of a malfunctioning gland. In secondary disorders, e.g., secreting lung carcinoma, heart failure-induced hyperanemia, renal failure-induced hyperparathyroidism, the gland itself is doing what it is told to do by other controlling forces, e.g., pituitary gland, hypothalamus, tumor, disease. They are the problem, not the gland. 32. Corticosteroid side effects: weight gain, easy bruising, acne, hirsutism, emotional lability, depression, psychosis, menstrual changes, sexual dysfunction, insomnia, memory loss, buffalo hump, truncal and central obesity with wasting of extremities, round plethoric faces, purplish skin striae, weakness especially of the proximal muscles, hypertension, peripheral edema, poor wound healing, glucose intolerance or diabetes, osteoporosis, and hypokalemic metabolic alkalosis resulting from mineralocorticoid effects of certain corticosteroids. Growth can also be stunted in children. 33. Osteoarthritis is by far the most common cause of arthritis, 275% of cases, and usually does not have hot, swollen joints or significant findings if arthrocentesis is performed. Activate Windows 34. Cancer incidence and mortality in the United Activate States. Male, 1. Prostate, 2. Lung, 3. Colon, female, 1. Breast, 2. Lung, 3. Colon, 1. Lung, 2. Breast, 3. Colon, male, 1. Lung, 2. Prostate, 3. Colon. 35. Sequelae of lung cancer: hemoptysis, Horner syndrome, superior vena cava syndrome, phrenic nerve involvement/diaphragmatic paralysis, hoarseness from recurrent laryngeal nerve involvement, and paraneoplastic syndromes, Cushing's syndrome, syndrome of inappropriate secretion of antidiuretic hormone side, hypercalcemia, Eden-Lambert syndrome. 36. Bitemporal hemianopsia, loss of peripheral vision in both eyes, is caused by a space-occupying lesion pushing on the optic chiasm, classically a pituitary tumor until proved otherwise. Order computed. Tomography, CT, or magnetic resonance imaging MRI scan of the brain. 37. Potential risks and side effects of estrogen therapy, e.g., contraception, postmenopausal hormone replacement, endometrial cancer, hepatic adenomas, glucose intolerance/diabetes, DVT, stroke, cholelithiasis, hypertension, endometrial, bleeding, depression, weight gain, nausea/vomiting, headache, weight gain, drug-drug interactions, teratogenesis, an aggravation of pre-existing uterine lamiomas, fibroids, breast fibrinomas, migraines, and epilepsy. The risks: of coronary artery disease and breast cancer are increased with combined estrogen and progesterone therapy. 38. Object characteristics of a mole that should make you suspicious of malignant transformation: asymmetry, borders irregular, color change in color or multiple colors, diameter. The bigger the lesion, the more likely it is malignant and evolving over time. Do an excisional biopsy of such moles and slash, or if a mole starts to itch or bleed. 39. Bronchiolitis versus croup versus epiglottitis. Child's age. Common respiratory syncytial cause S virus or SV. 75%. Influenza. Symptoms slash signs. X-ray findings. 0-18 months. Yes. Treatment. Initial viral upper respiratory infection. URI. Symptoms, followed by tachypnea and expiratory wheezing. Hyperinflation. Humidified oxygen. Bronchodilators. Efficacy uncertain. Ribavirin used for severe RSV infection or high risk for RSV infection. Croup acute laryngitis. 1 to year. Yes. Parainfluenza virus 50%, 75% of cases. Influenza. Initial viral URI symptoms followed by barking cough, hoarseness, and inspiratory stridor. Subglottic tracheal narrowing on frontal X-ray steeple sign. Dexamethasone. Nebulized. Epinephrine. Humidified oxygen. 2-5 year. No. Haemophilus influenzae. Staphylococcus spp. Streptococcus spp. Rapid progression to high fever, toxicity, drooling, and respiratory distress. Swollen epiglottis and lateral neck X-ray. Thumb sign. Purpurito established and airway. Antibiotics e.g. third generation. Cephalosporin, an antistaphylococcal agent active against methicillin-resistant Staphylococcus aureus, such as vancomycin or clindamycin. 40. Sequelae of streptococcal infection, rheumatic fever, scarlet fever, and post-streptococcal glomerulonephritis. Only the first two can be prevented by treatment with antibiotics. 41. Multiple sclerosis should be suspected in any young adult with recurrent, varied neurologic symptoms slash signs where no other causes are evident. Best diagnostic tests: MRI most sensitive, lumbar puncture, elevated immunoglobulin G, oligoclonal bands, and myelin basic protein levels, mild elevation in lymphocytes and protein, and evoke potential slowed conduction through areas with damaged myelin. 42. For the unconscious or delirious patient in the emergency department with no history or signs of trauma, consider empirical treatment for hypoglycemia, glucose, opioid overdose, naloxone, and thiamine deficiency. Thiamine should be given before glucose in a suspected alcoholic. Other commonly tested causes are alcohol, illicit or prescription drugs, diabetic ketoacidosis, stroke, epilepsy or post-ictal state, and subarachnoid hemorrhage e.g. aneurysm rupture. 43. Delirium versus dementia. Onset. Common causes: reversible, attention, arousal, level. Delirium, acute and traumatic. Illness, toxin, withdrawal, usually poor. Fluctuates, dementia. Chronic and insidious, Alzheimer's disease, multi-infarct dementia, HIV/AIDS, usually not, usually unaffected. Normal activate windows. 44. Always consider the possibility of pregnancy and order a pregnancy test to rule it out, unless pregnancy is an impossibility in reproductive age women, before advising potentially teratogenic therapies or tests, e.g. antiepileptic drugs, X-ray, CT scan. Pregnancy is in the differential diagnosis of both primary and secondary amenorrhea. 45. Anaphylaxis is commonly caused by bee stings, Food allergy, especially peanuts and shellfish. Medications, especially penicillins and sulfur drugs, or latex allergy. Patients become agitated and flushed, and shortly after exposure develop itching urticaria, facial swelling, angioedema, and difficulty breathing. Symptoms develop rapidly and dramatically in true anaphylaxis. Treat immediately by securing the airway. Laryngeal edema may prevent intubation, in which case do a cricothyroidotomy if needed, and give subcutaneous or Roman 4 epinephrine. Antihistamines and corticosteroids are not useful for immediate, severe reactions that involve the airway. 46. Cancer screening in asymptomatic adults. Colorectal, colon, prostate, cervical, gynecologic, procedure, colonoscopy, flexible sigmoidoscopy, double contrast barium enemas CT colonography, fecal occult blood test, fecal immunochemical test, stool DNA test, digital rectal examination, prostate-specific antigen test, pap smear, pelvic examination. 50-year for all studies. 40-year, 50-year, beginning at age 21 or regardless of sexual activity. 2164-year, 265-year, frequency, every 10-year, every 5 or every 5, every 5, annually, interval uncertain, annually, controversial, but offer annually if conventional pap test is used. Test annually. Then every 2-3 year for women 30 or old who have had 3 negative cytology test results if pap and human papillomavirus HPV testing are used. Test every 3 years if both HPV and cytology results are negative annually after 3 normal examinations, every 4-3 year annually when the stop is not clearly established. Breast, lung. Breast self-examination, physical examination by doctor, mammography, sputum, chest x-ray, CT scan, 20-year, 20-40-year, 40-year, routine screening in the absence of symptoms. Benefits and limitations should be discussed. But breast self-examination is no longer recommended by the American Cancer Society every 3 years. Annually. Testing is not recommended for asymptomatic individuals, even if they are at high risk. Annual CT scan is controversial but may be indicated for smokers and former smokers aged 55-74 who have smoked at least 1 pack of cigarettes per day for at least 30 years. This table is for the screening of asymptomatic, healthy patients. Other guidelines exist, but follow this table for the USMLE. Controversial areas usually are not tested on the USMLE. Risks start at age 45 years in African Americans and at age 40 years for patients with a first-degree relative diagnosed at an early age. 47. Biostatistics calculations using a 2x2 table. Test or exposure. ACBD. Sensitivity, specificity, PPV, NPV, odds ratio, relative risk, attributable risk. A slasher plus CD slash B plus D, a slasher plus BD slash C plus D, a XD slash B XC, a slasher plus B slash C plus D, a slasher plus B C slash C plus D. 48. The p-value reflects the likelihood of making a type I error or claiming an effect or difference where none existed, i.e., results were obtained by chance. When we reject the null hypothesis, i.e., the hypothesis of no difference in a trial testing a new treatment, we are saying that the new treatment works. We use the p-value to express our confidence in the data. 49. Side effects of antipsychotics. Acute dystonia treat with antihistamines or anticholinergics. Akathisia beta blocker may help. Tardive dyskinesia switching to a newer agent may be beneficial. Parkinsonism treat with antihistamines or anticholinergics. Neuroleptic malignant syndrome. Hyperprolactinemia may cause breast discharge. menstrual dysfunction, and slash or sexual dysfunction, and autonomic nervous system related effects, e.g., anticholinergic, antihistamine, and alpha receptor blockade. 50. Asking about depression and suicidal thoughts/intent is important in the fight. Setting downs and does not cause people to commit suicide is to activate hospitalized psychiatric patients against their will if they are a danger to self or others. 51. Drugs of abuse. Those that are potentially fatal in withdrawal include alcohol or barbiturates, benzodiazepines, alcohol, cocaine, opiates, barbiturates, benzodiazepines, phencyclidine PCP, and inhalants are potentially fatal in overdose. 52. Pelvic inflammatory disease (PID) is the most common preventable cause of infertility in the United States and the most likely cause of infertility in younger, normally menstruating women. 53. Polycystic ovarian syndrome is classically associated with women who are heavy, HER2, and amenorrhea. It is the most common cause of dysfunctional uterine bleeding. Remember the increased risk of endometrial cancer as a result of unopposed estrogen. 54. Fetal/neonatal macrosomia is caused by maternal diabetes until proved otherwise. Use diet and insulin, not oral agents, to treat maternal diabetes. 55. Causes of low maternal serum alpha fed protein, Down syndrome, inaccurate dates most common, and fetal demise. Causes of high maternal serum alpha fed protein, neurotube defects, ventral wall defects, e.g., omphalosis, gastroschisis, inaccurate dates most common, and multiple gestation. Measurement generally is obtained between 16 and 20 weeks gestation. 56. Hypertension plus proteinuria in pregnancy equals preeclampsia until proved otherwise. 57. Positive pregnancy test, i.e., not a clinically apparent pregnancy plus vaginal bleeding and abdominal pain equals ectopic pregnancy until proved otherwise. Order a pelvic ultrasound if the patient is stable. 58. Decelerations during maternal monitoring. Early decelerations are normal and caused by head compression. Variable decelerations are common and usually are caused by cord compression. Turn the mother on her side, give oxygen and fluids, and stop oxytocin. Late decelerations are caused by uteroplacental insufficiency and are the most worrisome pattern. Turn the mother on her side, give oxygen and Roman 4 fluids, stop oxytocin, and measure fetal oxygen saturation or scalp pH. Prepare for prompt delivery. 59. Always perform an ultrasound before a pelvic examination in the setting of third trimester bleeding in case placenta previa is present. 60. Uterine atony is the most common cause of postpartum bleeding and is typically caused by uterine overdistension, e.g., twins, polyhydramnios, prolonged labor, and slash or oxytocin. Usage. 61. Acute abdomen pathology localization by physical examination. Activate windows. Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, epigastric area. Organ conditions: gallbladder/biliary cholecystitis, cholangitis or liver abscess, spleen rupture with blunt trauma, appendicitis, PID, sigmoid colon diverticulitis, PID, stomach peptic ulcer or pancreatitis. 62. The 6 W's of postoperative fever: water, wind, walk, womb, wallet, and weird drugs. Water stands for urinary tract infection, wind for halitosis or pneumonia, walk for DVT, womb for surgical wound infection, wallet for breast usually relevant only in the postpartum state, and weird drugs for drug fever. In patients with daily fever spikes that do not respond to antibiotics, Think about a post-surgical abscess. Order a CT scan to locate, then drain the abscess if one is present. 63. Observe trauma follow in order if you are asked to choose airway, breathing, circulation, disability, and exposure. 64. 6 rapidly fatal thoracic injuries that must be recognized and treated immediately. 1. Airway obstruction, establish airway. 2. Open pneumothorax, intubate and close defect on 3 sides. 3. Tension pneumothorax, perform needle thoracentesis followed by chest tube. 4. Cardiac tamponade, perform pericardiocentesis. 5. Massive hemothorax, place chest tube to drain. Thoracotomy if bleeding does not stop. 6. Flail chest, consider intubation and positive pressure ventilation if oxygenation is inadequate. 65. Neonatal conjunctivitis may be caused by chemical reaction in the first 12-24 hours of giving drops for prophylaxis. Gonorrhea 2-5 days after birth, usually prevented by prophylactic drops, and chlamydial infection 5-14 days after birth, often not prevented by prophylactic drops. 66. Glaucoma is usually 90% the open-angle form, which is painless, no attacks, and asymptomatic until irreversible vision loss that starts in the periphery occurs. Screening is thus important. Open-angle glaucoma is the most common cause of blindness in African Americans. 67. Uveitis is often a marker for systemic conditions, juvenile rheumatoid arthritis, sarcoidosis, inflammatory bowel disease, ankylosing spondylitis, reactive arthritis, multiple sclerosis, psoriasis, or lupus. Photophobia, blurry vision, and eye pain are common complaints. Activate windows. 68. Bilateral, although often asymmetric, painless, gradual loss of vision in older adults usually results from cataracts, macular degeneration, or glaucoma, which can be distinguished on physical examination. Presbyopia is a normal part of aging and affects only near vision, i.e., accommodation. 69. Compartment syndrome, usually in the lower extremity after trauma or surgery, causes the 6 PS. 1. Pain present on passive movement and off and out, a proportion to the injury. 2. Paresthesias, numbness, tingling, decrease, sensation. 3. Pallor or cyanosis. 4. Pressure, firm feeling, muscle compartment, elevated pressure reading. 5. Paralysis, late, ominous sign. 6. Pulselessness, very late, ominous sign. Treat with fasciotomy to relieve compartment pressure and prevent permanent neurologic damage. 70. Peripheral nerve evaluation. Nerve, radial, ulnar, median, axillary, peroneal, motor function, wrist extension, watch for, wrist drop, finger abduction, watch for, claw hand, pronation, thumb opposition, abduction, lateral rotation, dorsiflexion, eversion, watch for foot drop, sensory function, clinical scenario, back of forearm, back of humeral fracture, hand first 3 digits, front and back of last 2 digits, palmar surface of hand, first 3 digits, lateral shoulder, dorsal foot and lateral leg, elbow dislocation, carpal tunnel syndrome, humeral fracture, upper humeral dislocation, or fracture, knee dislocation. 71. Pediatric hip disorders, name, age, epidemiology. CHE at birth, LCPD, SCFE, female, firstborn, breech delivery, 4'10" or short, male with delayed bone, age, 9-13 or overweight, male, adolescent. Symptoms/signs, Barlow and Ortolani signs, knee, thigh, groin pain, limp, treatment, hardness, orthosis, knee, thigh, groin pain, limp surgical, pinning. CHG, congenital hip dysplasia. LCPD, like Calvé-Pur's disease. CFE, slip capital femoral epiphysis. Note, all of these conditions may present in an adult as arthritis of the hip. 72. Avoid lumbar puncture in a patient with head trauma or signs of increased intracranial pressure because of the risk of herniation. Perform CT scan without contrast instead. 73. In children, 75% of neck masses are benign, e.g. lymphadenitis, thyroglossal duct cyst, but 75% of neck masses in adults are malignant, e.g. squamous cell carcinoma and/or metastasis. Lymphoma 74. Manage symptomatic carotid artery stenosis of 70% to 99% with carotid endarterectomy. Less than 50% with medical management, e.g. antihypertensive agents, statins, and antiplatelet therapy and treatment of atherosclerosis risk factors. For stenosis between 50% and 69%, the data on management is less clear and patient-specific activate windows. 75. Pulsatile abdominal mass plus hypotension equals ruptured abdominal aortic aneurysm until proved otherwise. Perform an immediate laparotomy 90%. Mortality rate 76. Conditions best viewed as anginal equivalents, transient ischemic attacks, claudication, and chronic mesenteric ischemia. Arterial workup and imaging are indicated. 77. Cryptorchidism is the main identifiable risk factor for testicular cancer and can also cause infertility. Treat with surgical retrieval and orchiopsy or orchectomy. 78. Benign prostatic hypertrophy/hyperplasia can present as acute renal failure. Patients have a distended bladder and bilateral hydronephrosis on ultrasound neither is present with medical renal disease. Drain the bladder first, catheterize, then perform transurethral resection of the prostate term. 79. Impotence may be physical, e.g. vascular, nervous system, drugs, or, less commonly, psychogenic. Patients have normal nocturnal erections and a history of dysfunction only in certain settings. 80. The overall pattern of growth in a child is more important than any one measurement. Consider close follow-up and remeasurement of growth parameters if you do not have enough data. A stable pattern is less worrisome and less likely to be correctable than a sudden change in previously stable growth. For example, the most common cause of delayed puberty is constitutional delay, a normal variant. 81. Finding suspicious for child abuse, assuming that other explanations are not provided. Failure to thrive. Multiple injuries in different stages of healing. Retinal hemorrhages plus subdural hematomas. Shaken baby syndrome. Sexually transmitted diseases. A caretaker story that does not fit the child's injury or complaint. Child with behavioral or emotional problems and multiple personality disorder as an adult. 82. The AGAR score commonly performed at 1 and 5 minutes after birth. The maximum score is 10. Category: color, heart rate, reflex irritability, muscle tone, respiratory effort. 0 pale, blue absent none. Limp none. Number of points given 2. 1. Body pink, extremities blue, 100 beats/min. Grimace. Some flexion of extremities, slow, weak cry. Completely pink, 100 beats/min. Grimace and strong cry. Cough and sneeze. Active motion, good, strong cry. Asterisk reflex irritability usually is measured by the infant's response to stimulation of the sole of the foot or catheter put into the nose. 83. Diuretics are a common cause of metabolic derangement. Thiazide diuretics cause calcium retention, hyperglycemia, hyperuricemia, hypolipidemia, hyponatremia, hypokalemic windows metabolic alkalosis, and hypovolemia. Because theta vape are sulfur drugs, watch out for sulfur allergy. Loop diuretics cause hypokalemic metabolic alkalosis, hypovolemia more potent than thiazides, toxicity, and calcium excretion. With the exception of ethacrenic acid, they also are sulfur drugs. Carbonic anhydrase inhibitors cause metabolic acidosis, and potassium-sparing diuretics e.g. spironolactone may cause hyperkalemia. 84. Overdoses and antidotes, poison or medication. Acetaminophen. Benzodiazepines, beta blockers, carbon monoxide, cholinesterase inhibitors, copper or gold digoxin, iron. Lead methanol or ethylene glycol muscarinic blockers, opioids, quinidine or tricyclic antidepressants. Antidote, acetylcysteine, flumazonyl glucose, oxygen hyperbaric in cases of severe poisoning, atropine, pralidoxime, penicillamine, normalized potassium and other electrolytes, digoxin antibodies, difuroxamine, etate, usuximar in children, fompizole, ethanol, physostigmine, naloxone, sodium bicarbonate, cardioprotective. 85. Aspirin/non-steroidal anti-inflammatory drugs, NSAID side effects, GI bleeding, gastric ulcers, renal damage e.g. interstitial nephritis, papillary necrosis, allergic reactions, platelet dysfunction, life of platelet for aspirin, reversible dysfunction with NSAIDs, and race syndrome, encephalopathy, and or liver failure in a child taking aspirin in the setting of a viral infection. Aspirin overdose can be fatal and classically leads to both metabolic acidosis and respiratory alkalosis. 86. Central pontine myelinolysis, brainstem damage, and possibly death may result from overly rapid correction of hyponatremia. 87. Because of cellular shifts, alkalosis and acidosis can cause symptoms of potassium and or calcium derangement, e.g. alkalosis can lead to symptoms of hypokalemia or hypocalcemia. In this setting, pH correction is needed rather than direct treatment of the calcium or potassium levels. Magnesium depletion can also make hypocalcemia and hypokalemia unresponsive to replacement therapy until magnesium is corrected. 88. Adult patients of sound mind are allowed to refuse any form of treatment. Watch for depression as a cause of incompetence. Treat depression before wishes for death are respected. 89. If a patient is incompetent, including younger, minors who lack adequate decision-making windows, capacity, and an emergency treatment is needed, activate, seek a family member or court-appointed guardian. Treat as you see fit in an emergency or contact the courts in a non-emergency setting. 90. Respect patient wishes and living wills, assuming that they are appropriate even in the face of dissenting family members, but take time to listen to family members' concerns. 91. Always be a patient advocate and treat patients with respect and dignity, even if they refuse your proposed treatment or are non-compliant. If patients' actions puzzle you, do not be afraid to ask them why they are doing or saying what they are. 92. Break doctor-patient confidentiality only in the following situations. 1. The patient asks you to do so. 2. Child abuse is suspected. 3. The courts mandate you to do so. 4. You must fulfill the duty to warn or protect. If a patient says that he is going to kill someone or himself, you have to tell the person who is threatened, the authorities, or both. 5. The patient has a reportable disease. 6. The patient is a danger to others, e.g., if a patient is blind or has seizures, let the proper authorities know so that they can revoke the patient's license to drive. If the patient is an airplane pilot and is a paranoid, hallucinating schizophrenic, then authorities need to know. 93. Causes of false laboratory disturbances. Hemolysis, hyperkalemia, pregnancy elevated, sedimentation rate and alkaline phosphatase, hypoalbuminemia, hypocalcemia, and hyperglycemia, hyponatremia. 94. ECG findings of myocardial infarction, flipped or flattened out waves. ST segment elevation depression means ischemia. Elevation means injury, and slash or Q waves in a segmental distribution, e.g. Lee's Roman 2, Roman 3, and AVF for an inferior infarct. ST depression may also be seen in reciprocal / opposite Lees. 95. Drugs that may be useful in the setting of acute coronary syndrome: aspirin, morphine, nitroglycerin, beta blocker, AC inhibitor, clopidogrel, HMG or reductase inhibitor, glycoprotein IB/IR receptor inhibitors, heparin unfractionated or low molecular weight heparin, and tissue plasminogen activator TPA. Strict criteria for use. 96. Cholesterol management guidelines numbers in the chart represent mg/dl. No CHE risk factors. LDL 160. LDL 160, 189, 2190. 22 CHE risk factors. LDL 100. LDL 100, 129. LDL 2130. No CHD/equivalent. LDL 100. LDL 100. Very high risk. LDL 70. LDL 70, 99. LDL 100. Intervention. None meets goal. Diet medications plus diet. Risk CHD. Coronary heart disease. Risk factors for CHE are listed in Chapter 4. Asterisk CHD equivalents include diabetes mellitus, peripheral arterial atherosclerotic disease, symptomatic carotid artery disease, and abdominal aortic aneurysm. Very high risk patients are those with CHE who have a heart attack, diabetes, or other severe and poorly controlled risk factors, e.g. metabolic syndrome, heavy smoking. $*diet includes general lifestyle modifications, such as eating less and healthier, decreasing alcohol intake, and exercising. The trend is toward more aggressive intervention, so you will not be faulted for initiating medications at these gray area LDL levels, particularly in high-risk people. 97. Type 1 versus Type 2 diabetes. Age at onset. Associated body habitus. Development of ketoacidosis. Development of hyperosmolar twin concurrent human leukocyte antigen association. Response to oral hypoglycemics. Antibodies to insulin. Risk for diabetic complications. Islet cell pathology. Most commonly, 30-year thin state. Level of endogenous low to non-insulin. Yes. No. 50%. Yes. No. Yes at. Diagnosis. Yes. Insulitis, loss of most B cells. Type 2, 90% of cases. Most commonly 30. Obese. No. Yes. Normal to high. Insulin resistance. No. Yes. No. Yes. Normal number. But with windows. Findings may overlap. 98. Hypertension classification. Systolic BP asterisk diastolic BP mmHg mmHg. 80, 89. 90, 99. 120. 120, 139. 140, 159. 160, 100. Classification. Normal. For hypertension stage, a hypertension stage Roman 2 hypertension. Asterisk classification is based on the worst number, e.g. 168/60 mmHg is considered stage Roman 2 hypertension even though diastolic pressure is normal. 99. Word associations not 100%, but they can help when you have to guess. bus phrase or scenario condition. Friction rub pericarditis. Cosmo breathing deep. Rapid diabetic ketoacidosis breathing. Case of flesh or ring in the eye, bid-eye spots. Dendritic corneal ulcerzone. Fluorescein stain of the eye. Cherry red spot on the macula without hepatosplenomegaly. Cherry red spot on the macula with hepatosplenomegaly, bronze skin plus diabetes, malar rash on the face. Meconium ileus rectal prolapse. Wilson disease. Vitamin A deficiency. Herpes keratitis. Salty tasting infant cafe au lait spots with normal IQ. Tay-Sachs disease. Niemann-Pick disease. Hemochromatosis. Systemic lupus. Heliotrope rash, purplish rash on dermatomyositis, the eyelids. Clue cells. Erythematosis. Gardnerella vaginalis infection. Cystic fibrosis, cystic fibrosis, cystic fibrosis. Neurofibromatosis, activate windows. McCune-Albrightings to activate syndrome or tuberous. Worst headache of the patient's life. Abdominal stride. Honey ingestion. Left lower quadrant tenderness / rebound. Children who torture animals. Current jelly stools in children. Ambiguous genitalia and hypotension. Cat-like cry in an infant. Infant weighing more than 10 lb. Anaphylaxis from immune globulin therapy. Postpartum fever unresponsive to broad-spectrum antibiotics. Increased hemoglobin at home and anemia. Heavy young woman with papilledema and negative CT/Mr. scan of hand. Subarachnoid. Hemorrhage. Cushing syndrome or pregnancy. Infant botulism. Diverticulitis. Conduct disorder. Intussusception. 21-hydroxylase deficiency in girls. Cry-Duchess syndrome. Maternal diabetes. Iga deficiency. Septic pelvic thrombophlebitis. Thalassemia. Pseudotumor cerebri. Low-grade fever in the first 24 HR eclipses after surgery. Bilateral hilar adenopathy in an African American patient. Sudden death in a young athlete. Fractures or bruises in different stages of healing in a child. Absent breath sounds in a trauma patient. Shopping sprees. Constant clearing of throat in a child or teenager. Intermittent bursts of swearing. Cholecystosis. Rash develops after. Administration of ampicillin or amoxicillin for sore throat. Daytime sleepiness and occasional falling down, cataplexy. Facial port wine stain and seizures. 100. Signs and syndromes. Post-traumatic stress disorder. Sarcoidosis. Hypertrophic obstructive cardiomyopathy. Child abuse. Pneumothorax. Mania. Tourette syndrome. Tourette syndrome. HPV or cytomegalovirus. Epstein-Barr virus. Infection. Narcolepsy. Sturge-Weber syndrome. Babinski sign. Beck triad. Brzezinski sign. Charcot triad. CH-Vostok sign. Courvoisier sign. Cullen sign. Cushing reflex. Gray-Turner sign. Humming sign. Stroking the bottom of the foot yields extension of the big toe and fanning of other toes, upper motor neuron lesion. Jugular venous distension, muffled hard sounds, and hypotension, cardiac tamponade. Pain on neck flexion with meningeal irritation, meningitis. Fever/chills, jaundice, and right upper quadrant pain, cholangitis. Tapping on the facial nerve elicits tetany, hypocalcemia. Painless, palpable gallbladder plus jaundice, pancreatic cancer. Bluish discoloration of periumbilical area, pancreatitis with retroperitoneal hemorrhage. Hypertension, bradycardia, and irregular respirations, high intracranial pressure. Bluish discoloration of flank. Pancreatitis with retroperitoneal hemorrhage. Calf pain on forced dorsiflexion off foot, DVT. Lariche syndrome. McBurney's sign. Murphy's sign. Ortolani's sign/test. Prain sign. Ropsing's sign. Tindall's sign. Trousseau's sign. Virchow triad. Pain in the left shoulder, ruptured spleen. Claudication and atrophy of the buttocks with impotence, aortoiliac occlusive disease. Tenderness at McBurney point. Appendicitis. Arrest of inspiration during palpation under the rib cage on the right cholecystitis. Abducting in infants' flex hips causes a palpable/audible click in genital hip dysplasia. Elevation of a painful testicle relieves pain. Epididymitis versus testicular torsion. Pushing on left lower quadrant then releasing your hand produces pain at McBurney point. Appendicitis. Tapping on the volar surface of the wrist elicits prestigious carpal tunnel syndrome. Pumping up a blood pressure cuff causes carpal spasm tetany from hypocalcemia. Stasis, endothelial damage, and hypercoagulability risk factors/foredos.